for about 3 years, 3 events a year where we invite speakers on very pertinent topics in the mental health field. And today we will definitely have a very, very in-depth discussion. And as we usually get involved starting, we would like our senior rabbi from Peninsula Temple Sholem to come up, Rabbi Daniel Feeder, for a couple opening comments and sincere thoughts that will kick off our meeting. Thank you.
So good afternoon, everybody. I'm Rabbi Dan Feeder. I'm the senior rabbi at Peninsula Temple Sholem. And I'm actually a stand-in for Rabbi Lisa Delson, who is our associate rabbi and really has captained our mental health initiative, which we call Panim El Panim, which in Hebrew means face to face. And we perceive in our community that the number one matter that was on people's minds was mental health. And that there's no area that we could focus on that could be of more importance to the community as a whole and to individuals than this subject. And we saw that among younger people, we saw it among older people, and everybody in between. And so we have made this a central part of who we are as a faith community. And if you are from the Peninsula Temple Sholem community and you have been active in either Panim El Panim or Let's Talk Mental Health, would you rise for a moment so that our community can recognize your efforts? Thank you. So Bob and Judy and Nikki and Marcy, thank you. And we think that communities of faith have the potential not only to make a difference in their faith communities, and not only to reduce stigma and to provide important resources for people and a safe haven, but also that faith communities in particular can bring something to the table that other communities cannot. Thank you all for being here, and may our coming together to learn, to share, and to heal be heard on high. Amen.
Amen.
Thank you. Thank you, Rabbi. I have a couple thank yous for people that have made this possible other than the temple. Number one, Leslie over here is staffing all of the brochures from NAMI. Many of you are familiar with the NAMI, I'm sure, the National Alliance of Mental Health, a great resource center for their own speaking engagements that they put on once every several months in San Mateo, a great resource center for those who need immediate help and knows how to deal with family-to-family issues. A terrific organization that's nationally based, and they do fun things too. Come September, if you're not aware of it, they have what they call the NAMI Walk, which is done nationally across the country, and she has information on that if you're interested in the NAMI Walk. It's a great place to go for some healthy exercise, not overly strenuous, with your friends and to make new friends. That's what it's all about. So please see Leslie afterwards, and she'll help you with any information that you'd like to gather from that organization. And then we'd like to thank the California Clubhouse, our executive director, Erica Horn. They've made it possible for us to coordinate the logistics to get this set up. Another wonderful resource for those in our community, family, friends, the overall general community who need resource help, training, often job placement help. This is a phenomenal organization that I believe is 4 years old in San Mateo County. And Erica would like to make a couple comments, and then we'll introduce our speaker of the day. Thank you. Erica?
I just wanted to say thank you and welcome to California Clubhouse. It's our pleasure. Thank you, Iris. I pay her. Anyway, she goes to all my gigs. I just wanted to say thank you so much for coming. It's our pleasure and our honor to be able to host this. We were so excited to be able to give this opportunity to the temple, and we just love what you are doing in the community and having conversation, because really we know that the first step to healing the world, but our local communities, is by discussing and talking and being open and having conversations about the tough stuff. Because if we converse and we discuss and we talk, maybe we'll be less likely to hurt each other or to resort to other means. And so we're very thankful to be part of this wonderful and meaningful opportunity that our greater San Mateo community gets to enjoy. I just wanted to say that California Clubhouse is a program for adults 18 and up living with serious mental illness. We open our doors. You are in the heart of the Clubhouse right now. We open our doors to members. We have a membership-oriented organization, so members get to restore their personhood from patienthood. We don't have patients or clients or consumers. We have members. They join our community at free will, because with membership comes opportunity, comes rights, privileges, but also comes accountability and a sense of belonging to something bigger than yourself, a community. And so right now what you see is the Clubhouse, everything. I took, what was your name? Lottie. I took Lottie on a tour earlier. I'll stay after if anybody would like a tour. Peter might be able to help me, or Iris, Bobby. So yeah, we would love to give tours, but everything you can see and experience while you're here is all the product of members and staff working side by side. We have a very small staffing so that members rise to the leadership occasion. And so we thank you again for coming. If you have any questions, bathrooms, I should tell you where the bathrooms are. That's always a good point. There's one right there. That's one bathroom, and then there's a bathroom in that direction as well, the great door past the kitchen area.
Yeah, this one has the, for handicapped.
Correct. Thank you. And there's an info table also over there about California Clubhouse. The members and staff set it up before they left work on Friday afternoon, so if you want to breeze by there, we have information packets and different things, and again, I'll be available to answer questions. And I want to say that this topic is very meaningful to us. We experienced a very considerable loss this year. Our founder, her son died by suicide, and so this is a very big component. It's been a healing process that our community has been going through together, and we honored Brian's memory by naming our cafe Brian's Cafe, and so we're very, very happy that this is the topic that came to the Clubhouse. Thank you and welcome.
Thank you, Erica. And before I turn the presentation over to Nargis, is that you'll notice that you have some 3x5 cards and a bunch of pens on each table. If you have any questions that you'd like answered during our Q&A session after her presentation, please fill out any of the cards. And we have several of our PTS membership folks here that will come by and pick up the cards. If you have a couple filled up on the table, just wave them and we'll pick them up. We'd like to get them in order so we can get to as many of them right afterwards when the presentation is done. Now it's our pleasure to introduce Nargis Zuhuri Dillon. Nargis is a licensed marriage and family therapist and a department director at Star Vista, where she oversees suicide prevention efforts along with other mental health efforts. I've had to learn a bit about Star Vista. They have been around for more than 50 years, and they have helped people throughout San Mateo County navigate life's challenges involving counseling, crisis prevention, youth housing, and early childhood programs. Nargis, thank you.
Hi everyone, thanks for being here on a Sunday. I'll speak up so everyone can hear me. I talk about this topic quite a lot. This is kind of a pretty big part of my role, is to go to different communities and talk about the topic of being well and the topic of what we can do if we're worried about someone in our life. We think they might be thinking about suicide. And for today we're going to talk a little bit about how we can remain a supportive community after we have lost someone to suicide. I know in my own life, as well as a lot of the families I work with, that's a piece I think that people have almost a harder time talking about. So we want to make sure we kind of address all of those different pieces. If throughout my presentation something comes up for you, you want to share something that you've experienced that feels different from what I'm saying, I value that. Don't feel uncomfortable saying, you know, you're saying these are the facts and yet this was different for my family, this was different for me. I think that makes the learning process richer when we get to hear from each other. These things ideally are conversations, and yet today it's going to be pretty didactic. I'm going to be kind of making a lecture for a little while here. So I appreciate opportunities for people to give input, to share a thought that comes up for them, or share an experience that they feel like it's comfortable for them to share with the rest of the group here, because I think that is the meaning of us knowing that we're in community with other people who really care about this topic and care about each other. Here we go. So our Vista, we have lots of different mental health programs all throughout San Mateo County. Our main office is in San Carlos, just down the road. We serve a lot of different schools. We have a lot of drug and alcohol programs. And our crisis center itself, we're part of the National Suicide Prevention Lifeline, so a lot of people who might be calling the crisis center or think they're calling the national line, if you're calling from San Mateo County, you're actually coming to our center in San Mateo. We've been around for 52 years. We do have staff on site overnight as well as during the daytime when we have volunteers on site. We get about 13,000 calls a year, just to kind of give you a sense for our call volume. And about less than 10% of those folks are in what we would call an active crisis. The rest of the 90% are calling us because they've had a really bad day or that they're worried about someone in their life. And I start with that because I want to normalize asking for help. I want to make it clear that people don't have to be in crisis before they reach out and say, hey, I need some support. And if there's something that you all could take away from this conversation today, would be letting other folks in your lives know that they don't have to wait until things feel unhandleable before they are asking for help. That the bad day is a great day to ask for help. The day where we feel alone is a great day to ask for help, and kind of encouraging help seeking as opposed to putting on a brave face. I brought lots of material and they're kind of sharing a table with Melanie if people want to grab something at the end. So the framework of this conversation initially is around mental wellness, and the reason we start the conversation like this at the very least is that so we are all on the same page in terms of what are we working toward? What's our hope here? And mental wellness feels like a better hope than just a lack of mental illness. You know, if we start the conversation by just defining what mental illness is, we still haven't really talked about what would it feel like to be well. So I like to kind of get our minds in that place before I do share quite a bit of information about things to look for. Some things that I think about when I'm talking to someone and I'm talking to them about wellness is, are they able to navigate kind of life in a way that's age appropriate for them? Are they able to have social relationships that feel fulfilling? So this could be family, this could be peers, this could be coworkers, it could be romantic. Not everybody has all of those things or needs all of those things, but do they have relationships that feel fulfilling for them? What's it like when a change happens? Is a change something that people are able to adapt to and get through, or is a change something that has derailed kind of their everyday life? Are they able to utilize appropriate coping? What does that mean? When a stressor happens, when there's a really bad day, does someone know what are some ways to make themselves feel better? Or is one bad day enough to really kind of derail us? Do we know where to ask for help? And are we able to navigate the different kind of environments that we have to be in? Because we act differently at home, at school, and with our family, with our friends, with our boss. So the ability to go back and forth between those different settings, that's something that is part of feeling well. How does that sit with people, that definition of what it might be like to be well? And I think it's a definition that helps us also check in with ourselves. Because there's a lot of distance between being well and being ill, mentally ill, like having a diagnosis or something like that, that people don't talk about. And that's actually this giant space where I want people to be asking for help. That's where so much healing happens. So to ignore all of all of us, all of everybody who might be in that space. I think that's a disservice to this conversation. The next thing I usually talk about is stress. And the reason I talk about stress is people are comfortable talking about stress. People almost like talking about stress. People compete about their stress at times. They might talk about how much they work as if that's some sort of like, there's a sticker for that. Or people might talk about young people, how busy they are, or how many activities they're doing, or, so stress is something that comes up pretty naturally in conversations, even among people that we don't know that well. You might be in an elevator with someone and you're like, oh, I was up so late working on this project. And it's like, that's us talking about our stress. So stress is a great entry point to talk about mental well-being and mental illness, because it's one that people aren't afraid of talking about. Yes, please.
I also think it's a good example of what I'd like to see mental health be talked about. Like 40 years ago, people didn't talk about stress. That wasn't a word. And so now you're indicating like it's so much. We're talking about it too much. Well, hopefully we can get that way with other things.
For sure. And we hear like really young, even school children, like elementary schoolers talking about being stressed out. And you could say maybe they heard some of their grown-ups saying those things, but I think it's also just a word that we now give everyone permission to be stressed, and that's not a bad thing. It's a good thing, because that means that they know how to talk about it, and they talk about it pretty openly. I do want to kind of make a differentiation. People ask a lot about toxic stress in recent years, because there's been a lot of research that has come out, and the difference between kind of your everyday stress and toxic stress is there is no end in sight with toxic stress. So it's something that's happening repeatedly to someone. So it's over a long period of time, and there's really no end in sight. And that is very different from the stress of, I was stressed coming here because I wasn't expecting traffic on a Sunday. I live in the East Bay. That was stressful, like unnecessarily stressful. I was just sitting on the bridge being like, really? Like on a Sunday afternoon? That's a stress that I was able to cope with. I took a couple breaths, I said, it's fine, people are coming, they'll get some cookies, they'll be okay. Right? I was able to kind of come back to my center so I can stand here right now. But toxic stress is things like chronic homelessness, it's chronic illness, it's living in violent neighborhoods or homes. Those are things that folks might not be able to imagine not having to deal with, and therefore that's not your everyday stress, and I don't want to minimize what that might feel like for people. How do we want to model talking about stress? Because this is great practice for how I'm going to ask us toward the end to talk about mental health as a way to actively be doing stigma reduction work just by living our lives. Which is do it often, but always pair it with coping. So when you are talking about stress to someone, especially that you might be worried about their stress, being like, when I'm stressed out, things that help me are X, Y, and Z. So you're acknowledging being stressed, you're acknowledging needing to do something specific to deal with that stress, and then you might be making room for the other person to share what works for them. What are some things that help you? So that really creates a culture where it's okay to be stressed and it's okay to ask for help or to be doing specific things to address it. And it's a culture of help-seeking and healthy coping. And it gives permission for people to not be okay. So think about when you walk up to someone, hey, how's it going? Oh, good. And sometimes you're like, really? Like the person just doesn't look like things are okay, but we're just trained to say we're doing okay when someone asks us how we're doing. And if you're just like, how's that? And you ask two more questions and you hear, oh, things are actually not okay at all. But initially the person might not have felt like it was okay to say that. So we want to create like environments and communities where people can say they're not okay and that there's no negative outcome for that. That I could show up here today and say, X, Y, and Z was really stressful for me. So it took me a while to be okay, and this is what I did to get okay. And that you're all not going to judge me for that because you can kind of relate to that experience. But so often, especially people in leadership roles, find it that they have to pretend to be okay all the time. This is something that has come up quite a bit. They feel like being a role model means role modeling being okay, whereas actually it would be a lot more impactful if people role modeled how not to be okay and cope with that. And this is really important for parent-child relationships, where parents so often hide so much of their not okay from their children, so that when their children feel not okay, they could feel like they failed. Because mom and dad, or the parents or guardians, have always been okay. And this is something that comes up quite a bit when we do schoolwork. Any thoughts? Yes, please.
Is there a social, societal risk to trivializing stress? When I think about the number of times a day, for example, my congregants talk about stress, and we're not talking about chronic illness, we're not talking about homelessness, we're not talking about crime.
Yeah.
And most of those stressful situations will never end. That's life. And I wonder if we've gotten, if we're trivializing stress to the point that it's maybe not so helpful.
And do we have the kinds of relationships or have the kinds of communities where we can then ask the follow-up question? And being like, what's underneath that stress? Because, the last 10 times you and I have talked, stress has been the answer to how are you feeling. So some the stress, like acknowledging the fact that the stress for that person is not feeling temporary anymore. So that's the shift, right? That's the shift that could help us use stress as a door opener, but get to that deeper thing. Yes.
One of the ways I relieve stress is to eat.
I appreciate that. Does that help in the moment?
Yeah.
It helps me too. Yeah. Does afterwards, do you feel like the stress kind of finds its way back?
Yeah. Well,
Yeah.
no.
No?
Definitely helps.
So your eating is working a little better than my eating. Because my stress finds its way back.
Okay.
And sometimes then it's like, okay, so I clearly didn't address what was underneath it. Yes, please.
Are you going to talk later about the kind of follow-up questions that would be helpful?
Yeah, when I talk more specifically about suicide, I will talk about questions to ask, things to not say specifically, and the reasons why. Yes,
How do you
please.
differentiate between stress and anxiety?
We are 3 slides away from that. That's it. So, stress is not just something we say and it's over. It can really actually impact our body. And it can feel like headaches. It can feel like a heaviness on our shoulders, tiredness. It can feel like stomach problems, sleep problems. It can impact our mood, make us feel worried, restless, not feel motivated. It can make us feel sad. So it's not a small thing. It can change our behavior. We might end up overeating or undereating. We might kind of yell at someone without meaning to. We might use drugs and alcohol as a way to deal with it, and that could work momentarily, or it could also have its own stress associated with it, depending on what happens after that. It can make people withdraw because they might not want to be around other people when they're stressed out. And this is something to put a pin in, because I'm going to talk about withdrawing as something that we worry about quite a bit as we keep going. They might just be not taking care of themselves as well. And this is just kind of a little tool that people have found helpful. I do a whole session on this tool when I work with parents of middle schoolers. But the idea is like we can all really use this as a way to better understand our own stress and try and kind of go beyond just saying that we're stressed out. And tracking it is really helpful. So like I, for a while, was tracking it on my calendar, literally. Like the parts of the day where I was feeling really stressed out, I would just make a note next to what was happening for me. So that at the end of the month, I could look at what patterns were emerging. Oh, whenever I'm going to this place or meeting with this person, I'm feeling additional stress. Or whenever I'm having to drive from East Palo Alto to Daly City, from one thing to the other in San Mateo County, that seems to be a lot for me. And some of those things I was able to actually make adjustments around, and some of them I wasn't, but at least understanding that, oh, this stressful thing is coming up next week, maybe I'll give myself a half-hour break after it, really changed my overall amount of stress that I was experiencing in a week. And then identifying what are the barriers to success. So like, as I said, not everything that stresses us can be just acted upon and it doesn't all go away. So what are the things that are keeping us from meeting those challenges or addressing those challenges instead of having to kind of coexist with them. And that's just helpful things to be thinking about and sort out for ourselves. And then, is there something we can do about it? And even knowing that there's certain things that you can control and other things that you can't, that in itself is a lot more empowering than just feeling stressed and not knowing what's going on for you. So this is something that we teach kids, we teach adults, like most of us can do this. Most of us can begin to track when we're feeling a certain way as a way to better understand our own process. Or we can help a loved one do that for themselves as well, if there's certain things that are coming up for them time and time again. As promised, here's a little bit about what it might look like if somebody is living with an anxiety disorder. So kind of just a quick note. I'm rushing through all of this because the bulk of what we want to talk about today is suicide prevention, but it feels important to kind of build up to it and think about all the other things that might be going on for someone. So just one slide does not do this topic justice, but hopefully it kind of gives people a sense of being on the same page in terms of how we're describing anxiety disorders at least. About 30% of adults at some time in their life have a diagnosable anxiety disorder. That's a pretty large number. So another topic that seems like a pretty comfortable topic to talk to folks about is actually anxiety, in my opinion. I think people are becoming more and more comfortable talking about anxiety, especially if you kind of not, like if you just talk about it being like really worried all the time. Like it's pretty approachable. People do talk about their worries. And then how do I differentiate between being worried and having it be so much that somebody is dealing with anxiety? And the way I would do that is thinking about it being excessive, so beyond kind of how much the situation warrants, and is it beginning to get in someone's way of living the life they want to live? So now thinking back to our initial thinking of like what would wellness look like, is how worried someone is about something keeping them from participating in their life. So let's say a lot of people have worries about public speaking, right? Thankfully that's not me, because this would be a very bad job as a public speaker. But a lot of people are uncomfortable about public speaking, but you know, if they have to do it once every 6 months, they'll get up in front of a group and talk about something. And they can kind of get over that initial kind of worry that they might have. But if that worry is so bad that every time they know they have to do that, they call out sick to work, that could become a problem, right? Because slowly, the whole week leading up to it, they might be thinking, oh, on Wednesday I'm not going to be able to go in, on Wednesday it's going to be so bad. And that internal dialogue can really keep people from being able to like carry out their life. So that's kind of one of the approachable ways that you can think about it, and I think everyone can kind of relate to that experience. So if you've had that running dialogue in your mind behind a night of a big event, now imagine having that almost all the time. Every day, all day, the constant worry about the next thing and the next thing, about social situations, about going to work, about driving in a car, about riding a bus. And it could feel like a lot. It could feel like a lot. And I think it's one that I hope people can find empathy for, because I think everyone experiences tastes of it throughout their life, but to try and imagine what it's like to have that be kind of the soundtrack to everything else that's going on every day, I hope you can kind of sit with that sense. When you are talking to a loved one or having empathy for yourself and your experiences as well. Yes, please.
So does that mean stress is basically a lot less than anxiety? So
Yes.
it's another one of those continuum.
Exactly. And like if you think about it, stress is, like everyday stress is not something that, like it's something that could really impact someone over time, and we just talked about all of those ways it could impact us. But when we're talking about anxiety here, I'm talking about a diagnosable anxiety. So it has to be at a level that is greatly impacting someone's ability to live their life. And it has a lot of things in common with the stuff I talked about with stress. And this is why initially a lot of times people might say, oh, I'm just stressed, that'll go away. And people take quite a long time to ask for help because they make the assumption that the symptoms they're experiencing is passing. And it's usually until it gets much worse and people are feeling like they're not able to live their life that they do ask for help around their anxiety. So I bet the number of people who actually live with anxiety is significantly higher even than the 30% who have received the medical diagnosis. Yeah, a lot of trouble sleeping, which then results in trouble with the daily tasks of life, you know, and it just kind of becomes a cycle. And social situations are a trigger for some people, but not for everyone who experiences anxiety. Same with leaving home. So different folks might have different things that they feel anxious about. Yes?
I was diagnosed being bipolar 2 years after high school. And it's really affected my wife, and that puts pressure on me, and it's hard.
I appreciate you sharing that. So you just shared one of the ways that it impacts your everyday life.
Yeah.
Yeah, I really appreciate you sharing that. Just a quick overview of what depression might look like for people. I think one of the misconceptions I want to address is when I ask people usually how they would describe depression. Sadness as the primary way that somebody is like living their life seems to be the thing at top of everyone's mind. But I do want to say that depression doesn't look like that for everyone. That there are many people who you would not visually observe as being sad all the time that do live with depression. So I think just challenging that assumption a little bit, that if somebody doesn't look sad, then they must not be depressed. So it's a lot. I think it's a lot more complicated than somebody expressing their sadness all the time. I think irritability is actually the way that sometimes it shows up more often. We specifically see this when comparing patients or clients who identify as male versus female, is that irritability and anger and a sense of kind of loss of who am I, like loss of identity, seem to be more present for folks than talking about sadness as the way that people feel all the time. So just holding that it might not look like what we think it might look like. Hopelessness and helplessness in general are things that we're always looking for. I'm going to talk about them a little bit more later. Loss of interest in activities. This is actually a really good one for people who belong to communities. Is there someone who always comes to one of these and they're not here today? They actually haven't been showing up to things recently. That's someone that we want to check in on. You know, and if they say, oh, I don't come to that anymore because now I'm taking tennis lessons at that time. Good for them. They have something else that they're interested in. But all of a sudden, if somebody is not interested in anything, I worry about that person. And the problem with that becomes that they're slowly also losing community. So they're losing things that might be bringing them joy, but they're also then not plugged into people who could keep an eye on them and ask them how they're doing. So then it just kind of gets on top of each other. Yes, please, Bob.
Who are you referring to in these matters, in these states of mental health?
Oh, so if somebody...
Suicide victims or suicide people who've committed suicide?
Oh, no, so this could be anyone who's living with depression.
Oh, okay, but is it leading to, this is the reason why they committed suicide?
Not necessarily.
Oh,
Not
okay.
necessarily.
Okay, thank you.
So the initial part of the presentation is just overview of, I would say, most common mental health challenges.
Okay, that leads to suicide.
Not necessarily.
Oh, okay.
I would say most people who live with a mental health challenge don't think about
Okay,
dying by
thank you.
suicide.
Thank you for bringing
Yeah.
it to our way.
So now just kind of statistically speaking, between the last one and this one, we're talking about a really significant portion of the population that's dealing with a mental health challenge. So really, this is just for us to actually realize that in every community we belong to, whether or not we choose to talk about it, we are amongst folks, and we might be the ones who are experiencing mental health challenges. So to not talk about it is a disservice, yes.
So did you say that most people with mental illness don't commit suicide?
Correct.
Okay, but 90% of people who do commit suicide have a
Correct.
brain dysfunction.
But there's such different numbers that we're talking about.
90% kill themselves?
No.
Oh.
90% of people who die by suicide did have a mental health challenge.
Oh.
But most people who have a mental health challenge don't die by suicide. Actually, most people who have a mental health challenge go on to recover. They go on to heal. They go on to find community. Was there a reluctant hand? No. Oh, and excessive feelings of guilt is actually one I want to mention. This is a cultural one. In cultures where folks might not talk as much about sadness or depression, they might be more comfortable talking about guilt. So on the crisis line, we actually do see this coming up quite a bit for people who talk about feeling guilty about having too many appointments, or feeling guilty that they're a burden on their family, or just that sense of guilt as the primary way somebody is relating to other people is something that feels a little more comfortable for people to bring up, but I want us to be aware of it, especially in communities where guilt is actually somewhat normalized, or kind of we joke about, like the Jewish guilt. Yes?
That is important. But it's a 17% of adults. What about youth?
I have some stuff coming up on youth before, but kind of some of the feedback I got about this presentation was kind of to keep it more focused on adults.
Do you know that I know that 100% of the suicide victims have been in family court services? Yes,
That's a pretty big life stressor.
yes.
Yeah,
They
thank
loan
you.
money to the court.
What percentage did she say?
100.
Oh.
Okay. Right.
Okay. So how do we talk about mental health with somebody? And this is kind of the last thing I'm going to talk about mental health before shifting a little bit into talking about suicide. But this is just everyday stuff. We want to validate the person's feelings. And what would this look like? Let's say somebody has recently had a breakup, right? They're upset, they're talking to us about it. For whatever reason, a lot of times when friends talk to each other about this, our desire is to help the person see their problem as smaller than they might be experiencing it. So what do I mean by that? You might tell a story about, well, I had this other friend who just got divorced, and then 6 months later, and she's doing so much better. So instead of sitting with the fact that, like, you're telling me you're really sad, you're telling me you're dealing with custody, you're telling me X, Y, and Z, we go to this place of wanting to make the person's problem feel smaller for them. I think it comes from good intentions. I think we're trying to help our friend or our loved one really kind of get through something, but I think some of that also comes from our own discomfort with sitting with sadness or sitting with emotions that we might not know what to do with. So really being aware of that. Are we giving advice, or are we talking more than the person we're trying to support because we're uncomfortable by what they're going through? And that happens so much. That happens so much. But I really encourage us to think about that. When we're the listener, do we end up talking more than we should because we're uncomfortable by the content? Or do we end up trying to distract the conversation to other topics to make it lighter because we think we're doing someone a favor? But in reality, next time, they're not going to talk to us about their problems. Because we just signaled to them that I can't handle it, or I'm not interested, or I only want to connect with you if it's about light, fluffy things. Yes?
Along those lines, another issue that I'm aware of is the fixer.
Mm-hmm. Yeah. And this comes up in all walks of life, you know, like this is the first thing they teach you when you become a therapist. Your job is not to fix people's problems. And sometimes people ask us to help fix their problem. But how that is basically kind of trivializing the magnitude of what they're going through.
But it's kind of a natural, you have kids, you fix their problems, you have people around you. And that's a natural thing to want to fix it.
Yeah. I suggest asking, were you looking for advice today? Before giving it. No unsolicited. Yeah. Were you hoping I would share advice today? And I say that to my friends, and the first time they kind of laugh, they're like, because people are so used to just getting advice. Like, most often they actually didn't want my advice. And speaking in a calm voice. I notice, I wonder. So this kind of goes back to what the rabbi brought up earlier, that people talk about their stress all the time. But they might be talking about something, and we can use that as an opportunity to notice. I notice every time you bring up the topic of Your housing, you end up being tearful. I wonder if there's something more going on. And no one has ever been mad at me for starting a sentence with this formula. It is a kind formula. It says, I see you. It's telling someone the way in which we experience them. It doesn't leave people defensive. And it's specific enough that shows them that we've actually been paying attention and we care about them. I noticed the last couple weeks you haven't been coming to the Clubhouse. Is everything okay? I loved when we did blank together. Right? We're reconnecting people to their communities. Say what you mean, but be prepared to listen. So I'm worried about you when, I don't know, you go without answering the phone for a couple days in a row. I'm worried about you when we make a lunch date and you don't show up. Try not to interrupt the other person. This is a hard one. Even when we're being a helper, we feel like we have all these good nuggets we want to get out. And we're just kind of sitting there waiting for our turn to say the good thing we wanted to say. That's not the good listening. Avoid sarcasm. You know, I think people use sarcasm as a way to deal with discomfort, but in a moment of really trying to sit with someone's pain or hearing them out, this is just not a good place for sarcasm. This was a hard thing for me to learn. That sarcasm was about me and not about the person that was going through something. Threats are not helpful in a situation like this. If you do blank one more time, then we can't be friends anymore. That tends to just worsen someone's internal process of feeling sad. Not making personal attacks or being demeaning. So when we're talking about noticing things, it's not about saying somebody's a bad person. It's about noticing a behavior. So trying to distance this specific thing that we're worried about from who they are, because we don't want the person to feel like they're being defined by a mistake or a thing that happened. And don't assume your answer is the only answer. Try not to use words such as always or never. This comes up in relationships a lot. You never take your dish to the sink after dinner. Like, really? Not even once? But people just don't hear us when we use words like that. You always ignore me when I'm upset. And when people make broad statements like that, it's really easy to not hear them. But yesterday when blank happened, I felt this way. That's more of a connecting statement as opposed to a distancing statement. So think about the goal of the conversation. The goal of these conversations is connection, not calling someone out on something they did, this is not like arguing in front of a court. We're not trying to make a case here. We're going for connection. So it requires us to maybe let go of trying to win in that same moment. And this happens because their worry turns into anger sometimes. If they're really worried about someone in their life, it comes out as anger toward that person at times. Deal with the now, not the past. So really staying with the thing that just happened, as opposed to being like, and 5 years ago when you did that, that was the same thing. Okay, that's not helpful. That doesn't build connection. Don't try and get the last word. If you get too heated or if it feels too emotional, take a break and come back to it. This is really important. I want us to keep talking about it, so let's talk some more. Acknowledge that you're in this together, if that's the case with who you're worried about or who you're talking with. We can do this. We'll look into some resources. I'll call some people. And then model talking about emotions, both good and bad. So this kind of goes back to what I said initially, which is ideally the only times we're talking about emotion are not when happy things happen. That throughout life in our communities we hold both the good and the bad enough that when bad things happen to people they don't feel like they can't come to hang out anymore, because this is the place where we only do bridal showers and baby showers and So we want to be able to hold that at all times in our communities, that there's room for both parts of people's lives. People feel okay? All right, so I'm going to shift. So now I'm going to shift to talking about suicide. I talk about suicide in a casual, matter-of-fact way, the same way I've been talking about mental health the whole time. There's a reason for that. I don't go hush hush, I do not say the word, because I'm wanting to model for you all how important it is to say the word and to talk about this. So this is intentional. This is not because I do this every day. I'm not desensitized. It's that every time it happens. And yet it's important for us to say the word so that someone in this room can say the word next time. I'm not going to go over all the stats. They're not particularly helpful to the conversation. The one thing I will say is the reason I include statistics is because sometimes there's this defensiveness that makes people say, well, it doesn't happen in our community. Well, Erica helped us not think that way from the very beginning. She said, it has happened in our community. And I've been working in San Mateo County for 14 years. I know it has happened in the community at the Temple Shalom. I know it has happened in every city on the peninsula. So anytime you're with someone and they say, oh, it's okay, it doesn't happen to our kind of people, that's because it's too scary to admit it actually does happen to our people. Because it happens, and it can happen anywhere. So hold that empathy for them as opposed to trying to be like, well, actually the lady said. But really holding, I can see how scary it is to think about it happening here. And that's validation as opposed to creating defensiveness.
Wait, how did you say that again?
I can see how scary it is to think about it happening here. I'll stop a second on data on age. This is interesting because I would say the most presentation requests I get is to talk about youth and teens. Because when youth and teens die by suicide, it impacts such large numbers of people because they belong to school communities. But from a statistical perspective, youth and teen suicide is actually not a very large percentage of suicides. What it is it tends to be very public. People who are dying by suicide the most are middle-aged folks. It's just they tend to be a lot more isolated.
Just repeat that.
Yeah, middle-aged and elderly people are more likely to die by suicide. Significantly more likely.
What's the percentage?
I had this. Hold on. I think over here we can kind of see it. So this is for 15 and younger. So you see how low it is. It's about 1% of suicides.
But they say 1 in 5.
1 in 5.
1 in 5 adolescents commit suicide.
So I'm going to talk about that. 1 in 5 has thought about it in the last year.
Thought about it.
Has thought about it. So there's quite a bit of data on adolescents, and I'll talk about it in a second. But when you look at the numbers of people who are dying by suicide, this is our 85 and older. That's our very top. This is 75 to 84, this pink line right here. 55 to 64, this blue line up here. So, just hold that. And yes, please.
Is there any statistics, I mean, I specifically know I've heard recently of several murder-suicides in, senior couples. Is there any statistics about that, or?
There is not. So the way this gets tracked by the Center for Disease Control is what the cause of death says on the death certificate. So that wouldn't be tracked. So the individual who died by suicide in that example would be tracked under suicide, and the other person would be tracked under homicide, and therefore there's not a lot of specific data on that. We work closely with CORA, which is Community Overcoming Relationship Abuse, which they do specifically try to prevent those situations, and yet there's not a lot of data on it.
Suicides don't get investigated as murders.
Correct?
Okay.
Yeah.
Right.
It's never, I'm sorry, what'd you say?
She said suicides aren't investigated like murders.
As murders.
It should be.
Just to rule
Okay.
it out.
We do work closely with the coroner's office, and I would say actually and this is kind of generally accepted, that the statistics on suicide are on the lower end because it does take quite a bit for a death certificate to state the cause of death as suicide. Yes, please.
Based on the data, it looks like, the age between 25 to 34 seems to be rising more rapidly than the other age groups. I mean, you know, looks like so. Was there any reason for that?
I could give you some like speculations, but the data that's presented nationwide isn't presented with reasons associated with it because there's really no way to track. We have theories. We have plenty of theories about all of these age groups. There's no way to track the ultimate reasons why people die. So during the Great Recession, suicide rates went up for anyone of working age because folks were losing their jobs.
In 2008.
Yeah, so between that, and then it took a long time for the economy to recover. It was only in the recent years when they say, okay, unemployment is low and things like that. And there was we noticed that even on the hotline, there was a huge increase in calls we were getting around people feeling a sense of like economic despair, but also a loss of who am I without this profession that I've been working in, or this thing that I've been working toward, or I have all this student debt, but now there's no job for me. So there was a huge, like the one thing that there is some consensus on for working age folks is that economic factors and the overall economic landscape of the country can contribute to people's well-being.
They were students?
Some. Okay, so why are adults at such high risk? Think about phase of life issues. So phase of life issues could look like people feeling more isolated. There could be mobility issues as people get older. There could be death of loved ones due to age or illness. There could be caregiver duties that could feel particularly like a hardship. There could be chronic illness. There is a lot of studies on chronic illness, age, and suicidal thinking. And there's also pretty easy access to deadly means. This is guns, medication, and also kind of societal piece, which is isolation. In the US, most people die using guns. This feels particularly heavy considering the fact that in the past 2 days, there's been 2 mass shootings in the United States. I'm not equating that with mental health. There's nothing showing that those folks were mentally ill. I despise when people equate mental illness and violence. But I wanted to speak to the fact that people have really easy access to guns. That's why I brought that.
And then when you say more people, they all died by guns, that's suicides?
Yes,
Okay.
significant, over 50%, about 50% of deaths by suicide in the US are by gun.
I just saw, all this stuff on TV about these 2 recent mass killings, and they showed a chart that 60% of deaths by guns are suicide. 38%,
Assuming homicide.
homicide, 38%, and 2% are mass killings.
Or accident, there's a lot of accidents.
Yeah.
Yes.
Is it a common assumption that when you mention a person has a mental illness, that the other person immediately assumes it's suicidal? The reason I say that, I had 2 experiences where one time my daughter who never was suicidal, the first thing I knew was it was spread around that she was suicidal. And then just recently, when I began to talk a little bit about it, the first thing that entered into the other person's mind was suicide. So is that sort of a common thing when you're talking about mental health and mental illness in a person, that the first thing that comes into people's minds is suicide?
Honestly, in my experience, the answer is no. Like, I don't feel like that's the case, unless the person has had their own has been thinking about that topic a lot, or has had something happen in their community, so they're feeling kind of extra thinking about it. I tend to deal with the other way a lot more often, where I'm saying like, your child told me they are suicidal, and people are like, oh no, they were just saying that. So I get the opposite of people being like, no, don't worry about it, that's just something they say.
This would be people who do not experience mental illness to say, well, it's suicidal. Or is it, they don't even ask whether are they suicide,
Yeah.
It's the first thing that comes into their head.
Does that, did that result in you wanting to talk to that person more, or wanting to be like,
Well,
I
I
don't
did
want to
try
talk
to
to you?
find out where she got the idea, but this has happened twice already.
Yeah, it sounds
And
like it kind of
I
stood
don't
out
get
for
that.
you. Yeah. It hasn't been my experience, but it's valuable to know that that's something that maybe didn't feel as welcoming to someone. That's good information for us to have, right? There's kind of some space between wanting to talk about the topic or bringing it up without really having any information.
But I do think that's interesting that you said the shooters don't necessarily have a mental illness, because that's definitely the assumption.
That is
Like, why
definitely
didn't anyone do anything? And I'm like, well,
So this kind of goes to a statistic that you brought up earlier. They do this youth risk and behavior survey nationwide. About 18%, that's about 1 in 5 students, do report that they had considered attempting suicide in the prior year. That's a really high number. So that's why I think there's a lot of energy around youth suicide, is because we know that youth are thinking about those things. And about 3% have made an attempt in the past year. But one of the things about youth is, when they make an attempt, many youth do live through it because of the nature of their attempts. So it's one part of the population where we get to talk to a lot of people who have survived an attempt and have quite a bit of information.
So do you have a percentage
Um,
of people
Oh,
surviving?
I had it. Yeah, the ratio of attempts to deaths in youth is 25 to 1. So every 25 attempts to death is 25 to 1.
Just to clarify, what's the age, age you are?
When we say youth,
Youth, yeah.
we're talking about, think about middle and high schoolers.
17
Like
years
13 to 18, yeah,
old.
just kind of as a grouping. But this survey specifically is done with high schoolers. Yeah, exactly. So it's done with high schoolers regardless of their age. Alright, so let's talk about risk factors a little bit. If we see what, we begin to worry about someone. I think this is kind of important to think about. If somebody is giving kind of warning signs, even if they're joking about it, and the joking happens if people say things like, if blank happens one more time, I'm just going to kill myself. So how can we kind of address that? Like, usually what I do is like, hey, when you said that, it kind of worried me. What do you mean by it? So I'm not kind of doing a full-on assessment. I'm just kind of checking in. And when you do that enough, people stop making that. If it's truly a joke, people stop joking that way because nobody enjoys that kind of halt in conversation. But we do say, hey, when you said that, what do you mean? Or when you say that, I worry about you. People might be giving away things that are really important to them. I have worked with people who began to try and make accommodations for their pets. If I wasn't around anymore, would you look after my cat? You plan on being someone? Tell me more. That's it. So when I say talking about it, is those follow-up questions. The sense of hopelessness about the future. What's the point? I won't be around for that anymore. This comes up around things that are like dates that a lot of people are looking forward to. So, like let's say people are making plans for something and somebody will say, oh, I won't be around for that anyway. I've had people as casually as that talk about something. And when I've asked, like, oh, what do you mean? Where would you be? They've said, I plan to kill myself. This had come up a couple of years ago at one of the high schools where somebody hadn't picked up their cap and gown and a teacher kept like pestering them. And finally the student was just like, oh, I won't be around for graduation. And the teacher's like, what do you mean? And the student said, I plan to kill myself before graduation. That's it. It was as simple as, and I don't think the teacher thought they were doing, like they were assessing for this. But the teacher just asked the follow-up question. What do you mean by that? Where are you going to be? Everybody else is coming to graduation. So any significant change in someone's work, social, and their behavior. And then living life without regard for consequences. This is such a hard one to like notice, but what it looks like, let's say somebody's doing risky things like drunk driving, and you try and bring it up with them. They're like, whatever, worst case scenario, I die. So it's kind of like devaluing that potential consequence. So they're not doing it with the hope of dying, but they're living a life that could result in it just based on the choices that are happening. Prescription medication, if someone's taking them, if they take more or less without talking to someone, that could be a huge risk factor. or someone starts taking somebody else's. We've had that. My friend's taking this and it really worked for them, so now I'm taking it too. Please don't. Let's talk to someone. Things that result in an increased risk. So just someone having one of those risk factors does not mean they're thinking about suicide, does not mean they're going to kill themselves. But there's things that we want to just check in about. We might worry about someone. These are kind of the extra highlighted ones. Substance abuse being one. People are more likely to make a decision more quickly when they're under the influence. A lot of folks who died by suicide were under the influence at the time. In San Antonio County, there's data on that. And then the other one that I will say, and this is one that I think, in past when I've talked to families of people who've died by suicide, this is the one that feels like the ultimate kind of punch in the gut, which is there is an unexplainable lifting of depression right beforehand. When somebody has a plan, I've spoken to a mom before who said, but I thought things had gotten better. And that's something that I've always held on to because it's so hard to notice that when we live with someone because there's this, okay, like things are finally getting better. So it's so hard to notice this. This is one that honestly I've only ever heard of people bringing up after the fact, but it's one that like in the national like curriculum we talk about, but I've never heard of someone who's noticed this and been able to get somebody help. It is so hard when we love someone to notice this because this is the thing we've all been working to. This is what we wanted to happen, right? So it's so hard for people to notice it. And so much of these things, I think, when we're so close to someone, so many of these things are so blurry. So I'm just holding that. So sometimes it's almost easier for people who are 1 degree removed to notice things, especially things like withdrawal or that sense of desperation, which is I would do anything for the pain to end.
So,
Yes.
I have a friend who always felt purposelessness. Like, didn't have motivation to go to work, feel bored at work. Goes home, feels so, what should I say?
Yeah. So somebody's sharing, just to repeat the question in case you didn't hear it, that they know someone who feels purposelessness all the time, and how can we help that person? I think, and the example you gave is around things like work, and acknowledging that maybe like work will not be a place that the person will find purpose, but if they could have a community in another way, or a thing that brings them joy outside of work. So I think people feel quite a bit of pressure for work to be something that gives them purpose, and when it doesn't, it feels like a place of shame and blame almost. So being okay with work not being that for that person, but is there something else in life that makes them feel like they are a contributor? So I think that would be where the opening is for someone who's feeling purposelessness right now. Yes, please.
Going back to the list,
Yeah.
if someone is working with a healthcare provider and they did notice that there's a lifting of depression and they call you and they're like, oh, should we be concerned? What would you do? Like, what would you recommend? Like, bring in the person and have a conversation?
Depending on what the other risk factors are, yeah, like if it feels so unexplainable and the person has been really chronically depressed for a long time, there might be an assessment that they would do. None of these things on their own are enough for anyone to act. That's the hard thing. Okay. How do we talk to someone about this? We don't express shock. And that's what I meant when I said I'm going to talk about it casually, because I want you to talk about it casually. Because if I was talking about this like it was some sort of secretive thing we were talking about, you wouldn't want to tell me anything, right? Because I'm building on the stigma by pretending this is something we shouldn't be talking about. So kind of keep that in mind. We talk like don't express shock if someone's talking about it. Know that you're not planting ideas in their head. They used to ask people like, what's the thing keeping you from asking someone if they're thinking about suicide? And they would say, well, I don't want to give them ideas. Well, now we know for a fact that that's not how it works. So asking someone, hey, like, as you're saying this, is this because you're thinking about dying or thinking about suicide? That's not giving them ideas. If I kept all of you here after this presentation and did a full-on assessment on every one of you, that would not be the thing that gave you that idea. Try and keep them just engaged in the conversation, even if it's not about the thing, but just that connection is helpful. It could be, it feels freeing. Ask directly, are you thinking about killing yourself? Are you thinking about suicide? Have you felt this way before? Are there other people we can talk to? And using I statements again, just as a way to not be confrontational. Identifying protective factors, so the idea is the same way that there's risk factors that make us worry about someone, there's also protective factors that can help kind of wrap someone up during a time that they're going through a lot. The one thing I will say is just because somebody has protective factors doesn't mean that then we don't have to worry about them. Oh, they're fine. They go to the synagogue every Saturday. We're good. So it's not like that. Ability to cope with stress. Spiritual beliefs, if the person has it. We don't recommend people go get spiritual beliefs, but if people have at some time belonged to a spiritual community, we do kind of try and encourage them to reconnect, because that could be a source of strength for them. Frustration tolerance, responsibility to family or loved ones, pets, positive therapeutic relationships, past or present, social supports, or access to support. And access to support is an interesting one. So there's studies that show if someone knows there's a place they could get help, even if they don't, that makes them feel better. What does that mean? That means like if you tell someone about the Clubhouse, about the crisis line, they don't have to call or come to feel better. Knowing that there's a place for people like them on its own makes people feel better. That's the power of programs like this existing in the community. That's the power of the numbers being up everywhere, on the TV, on the radio. The idea is we're telling people there are people who care about you. Sometimes people call the crisis line and then tell the volunteer, well, you're only talking to me because you're getting paid. Well, the volunteers get kind of offended when you tell them that. And actually that's the power of them being volunteers, is no, I'm here because I care. Like I care about whoever calls. We have staff too, and I promise you, the staff that do this work, they're not coming to work every day because we're paying their costs. Things not to say. So we don't want to, so first thing, if you've ever said these things, this is not to shame you. These things come from a place of love and a place of wanting to create connection, but what we know is they often result in creating distance. So that's why I'm bringing them up as a way to bring awareness to it, not to kind of make you feel bad. Asking someone, you're not thinking about suicide, are you? That creates a situation where there's only one right answer, right? You're not going to eat the last cookie, right? That's not really a kind way of asking it. Don't express disbelief. You would never do that. Don't be dismissive. You don't really mean it. Or saying kind of these grandiose things like suicide is selfish. Right? When people say these things, I think they're trying to help someone kind of get out of that state. They're trying to, what I call, create perspective, right? That's at least what people tell me. They're trying to create perspective. But what it results in is it results in the other person feeling not heard. Not creating this like philosophical conversation. Suicide is a permanent solution to a temporary problem. People say this a lot. People used to have this up in their offices. But it's just not true. Because we don't know what's going on for the other person. And the thing that they're experiencing might feel like, or it might literally be a lifelong problem. Not preaching. This is not the moment to talk about our personal or religious beliefs about suicide. So whether or not you think it's a sin or it's wrong, that's not really where this conversation is when we're worried about someone's safety. We don't ask confrontational questions. So why questions make people feel like they're in trouble? It's the principal's office. It's the parent. So let's say somebody walked in right now. Okay. Why are you coming in an hour after we started? Or saying like, is everything okay? You're an hour late. Assuming that something's going on for someone. And both of them are acknowledging the fact that somebody's an hour late, right? But they're very different conversations. Don't use guilt. Guilt and depression are already best friends. We don't add guilt to someone who might already be feeling sad. Can you imagine what this would do to your family? People have imagined. That's not the thing that will motivate them to learn. And don't promise to keep secrets. If I tell you something, you won't tell anyone, right? What do I say to that? And I'm a therapist, and I have all kinds of legal, ethical things. I say, as long as everyone's safe. That covers all of my things without making it sound all, well, the law says that, as long as everyone's safe. Because it also communicates to this other person that this is at the heart of our conversation, is safety. Some other things to say. I'm concerned about you. You're not alone. Who else can we talk to about this? The more people can be part of that support system, the less scary it is for you to hold this information, and also the more people can be helpful. Is there anyone else that knows? Is there someone we can call together? I'm here, I'm listening. Tell me what's going on. How long have you been feeling this way? I hope this makes you realize that this is a conversation you can have with someone. Some barriers to help seeking. This is something to keep in mind for ourselves and try and address as communities or in our families, which is what might be keeping someone from getting help. I think that's really important. We've kind of made the assumption today here that everybody's aware of the fact that stigma plays a big role in people asking for help. But stigma can be so multi-layered. There could be culture, religion, family of origin. There could be the internalized, kind of like the way the person sees themselves and their challenges. So I think we talk about stigma like everyone's on the same page, but really holding how complex stigma is and how powerful it is as a barrier. Fear. I think the fear of what will happen if I tell someone or if I ask for help. What would help look like? A lot of us don't know exactly what would help look like if I go to someone and say, this is what I'm experiencing. And that's really scary, that unknown of like, what's the next thing that will happen? And where can people go to get that information so that asking for help feels less scary? Sense of shame or blame. This goes both internally and for family members. Family members keep each other from asking for help sometimes because they feel like there could be associated shame or blame on them. That if my spouse is going through something, what are people going to think about me? If my child, this is so true for children, if my kid is going through something, it sure must be on me. And therefore, I don't ask for help because I don't want people to judge me, to think that I messed it up somehow. That's what keeps people from asking for help. So when people are talking to you about something and you say, like, have you talked to anyone? And they're like, no, I'm sure it'll pass, it's just a phase. Being like, what are you telling yourself about this? I ask people that all the time, because the story they're telling themselves about it is the thing that's keeping them from asking for help, or is the thing that's getting them to get help. They might be telling themselves, you know, better safe than sorry, so every time something comes up, we call the doctor. Okay, if that's the story of help seeking or whatever. But if the story is, well, my aunt got help and this is what it looked like and I don't want that for my family, so we're not telling anyone, that's a story that's keeping people from getting help. Families who one member has had a negative experience with help seeking, with the mental health system, that keeps tens of people from getting help when one person has had that negative experience. It takes a long time to build trust back with systems. And systems let people down every day, so like systems are not really helping themselves. Time, money, and access, these are your practical things. Like, I want a therapist and I have to wait like 3 months to get an in-network one, and I can only afford to go 10 times before I go broke, right? That's the reality. Building ongoing resilience. This is the idea of creating communities that are resilient and healthy. And what would that look like? It's communities that value help seeking, where people can show up as their whole selves, whether that be with their symptoms or with their bad days. They don't require us to pretend to be fine. They don't speak negatively of people who are struggling. So this is a tricky one. When somebody's not there, we assume what we say about them kind of, I guess it doesn't matter, they're not there to hear it. If I walked out of here and you all started talking about me, you would think, well, Nargis will never know this. But everybody in this room will hear how you talked about me and what I was going through today. And anyone who's going through a similar thing will not talk to anyone in this room about that because they just heard you talk behind my back. And I think this is the hardest thing to change in communities. How do we talk about the person who's not here and realizing the impact on all of the people who are here today? Place where we can talk about problems and solutions, or just talk about problems and not try and fix everything. And where we look out for each other's well-being. And then kind of how would that resilience look like if a community has experienced a death by suicide? Acknowledging that kind of anytime someone dies by suicide, a lot of people are impacted. people belong to so many different communities, and all of those people are impacted. And if those people are able to talk about that impact, that is building resilience. But if those people are not allowed to talk about that impact can really be very, very negative on their own well-being and on their families' well-being as well. Don't avoid the topic. People assume that the person who's lost someone doesn't want to talk about it. I think we say that because we don't want to talk about it. We're like, well, I'm sure they don't want to say anything about that. It's like, no, you don't want to say anything. So holding that. Whose discomfort are we really responding to here? Create space for grief and stories in a way that don't contribute to isolation. Deliberate inclusiveness, so going out of our way to pull someone back into the community after the loss. And bringing in outside support if we feel like our community is too impacted to support itself at that time. This happened at my office last summer. One of our staff went on a camping trip and died. Unexpectedly, not by suicide, but she was in her 30s. And we heard from a family member the next Monday that she wasn't coming to work and she had died. This is what we do all day, every day. And we had to call like another agency to come and help us because at first we were just trying to like therapize each other. Put 30 therapists in a room, no one's dealing with anything. And
Do
we
we
asked
have an evaluation after the death certificate to see if it's possible to be a murder?
I don't think that's kind of the relevant information here, honestly. But we brought on Cara, which is a grief agency, and they did sessions with all of us, with all of her clients. But really this idea, I think this happens in spiritual communities where the spiritual leaders are so used to holding the communal process that sometimes I think it's important to acknowledge we might be too close to the loss to hold that process. And it'd be helpful for an outside person to come in. And even if we are helpers all day, every day, we can't help ourselves in that way. And the other thing, and I don't know if maybe I did put it in. Yes, please, Erica.
I just want to say that we brought, I don't know if it was your team, I can't remember, I think it might have been your team that came in. We brought people in the very next day as well, and just sat around as a community, and because I was impacted,
Yeah.
and my staff were impacted as much as any member, and so it wasn't appropriate for any one of us to feel we needed to take the lead in the conversation. We just wanted to be part of the conversation, which was really helpful and very healing. But the other piece too is, one of the members actually pointed out that language was really important for her, and really challenged us as a community not to use the word committed suicide,
Yes.
because that makes it so, like they made a crime, like they were a criminal.
Yes.
It criminalizes the act. And then also, so she said, death by suicide.
Correct. Died by
Or died by
suicide.
suicide.
That's how I talk about it. Yeah.
And so we made a really concerted effort as a
Yes.
community to use that language. Yeah, and
That's
that's
really
really
important.
helpful.
Yeah, that is really important because language matters. It can, once again, it can bring us together or make someone be like, you're this outside person that this thing happened.
Or, that's right, and she also said, killed himself. She's like,
Uh-huh.
that just makes me, that's such a, agitating
Yeah.
statement. And so it really brought light to that for us as a community.
Yeah, I appreciate that. I feel like I don't have it, so I'm going to say it. Whatever community you belong to might have an existing way that you hold grief in your community. It's important for grief after suicide to look the same, that the grief is still acknowledged as grief. So it's okay to acknowledge that it was a suicide, but not talking about it because it's a suicide, saying, well, when this happens, people don't want to talk about it. So making sure you follow the same processes. The rituals are important to people. The rituals of grief are so important.
And then there's fear of it happening to you too.
Correct. Yeah, there's this fear that it's like contagious.
And it's never resolved as if, you know if it was suicide or a murder, or you don't know. And it's,
Yeah, the not knowing can be really hard.
yes, and you're faced with
It
this.
feels just unfinished.
And then trying to resolve it, you feel more fearful because you don't know how to talk about it, because you feel like if you talk about it to the wrong person, it could happen to you. It's like it raise a killer.
That's fine.
I know, it is. I think it's only one person.
I think reaching out to intentionally bring them together, and this is my last slide, so supporting with the same gestures of kindness that we would extend to others, which is taking meals to people and visiting them in their home, if that's something that your community usually does. talking about the deceased in the same way. We let people tell stories usually, we let people tell memories, and making sure we make space for that. And encouraging people to seek support. And this I'm not going to go over, but I have just some resources. The one thing I will clarify here, because somebody told me that this didn't make sense to them, it says call with a loved one. People are usually just really worried about calling the crisis line, so if you think somebody could benefit from calling, you could call with them the first time. And you could just say, hey, we're just calling to try it out. We get those calls all the time. So it's okay to call us like that, just to give someone a sense of it's not that scary to call the crisis line. This is the local number. This is the National Suicide Prevention Lifeline. There's a friendship line run out of San Francisco that's geared toward older adults. And we have a source for teens who don't want to call us because they don't want to talk to us. They just want to chat. It's called onyourmind.net. And there's a specific after-suicide toolkit here for people who want to create more communities that are more responsive or know how to respond in your community. Specifically one for religious and spiritual groups that was put together for the Suicide Prevention Resource Center. It's a national, it was a work group that came together to create guidelines for religious and spiritual communities to be able to be more responsive in a positive way. All right, questions? I think there's some sort of card system.
Yes, we collect any cards. Okay. Thank you.
Yes.
What is the suicide conversation for? Is it for like anybody who had lost their loved ones or their friends from suicide, or is it just or is this topic regarding about member that we currently
No, it's not
lost?
about one.
Yeah, the hope is this for everyone.
For us to open the dialogue as a community and host on it, how to help people interact with it.
Oh, cool.
So Iris is wondering who's the right audience for this, and the hope is everyone would have this information. Because everyone's community could at some point be impacted.
Well, this has been very, very interesting in that we've been encouraged to ask questions as we go along. We quite often get to the end of one of these presentations, and we have more questions that can be answered in the allotted time. So we've had many of them answered. I've had 2 cards turned in, and I'll read them, okay?
Okay.
Okay, let's start with the first one. Regarding barriers to seeking help. What do people do when access to services is delayed, such as a long wait period for therapy?
Yeah, I think this is something that is really common in the Bay Area right now, is that there's a shortage of mental health providers at most, even for folks who don't even need to use their insurance. People call places and say, I'm willing to pay all the money, can I just get services tomorrow? And the answer is usually no. There is long wait lists and things like that. I think depending on how worried you are, I usually have people go to their primary care. So that's a pediatrician or a generalist, or honestly most women go to their OBGYN, like their gynecologist. Those doctors are also trained to talk about this. So entering the helping world or going to peer support things, depending on the nature of things. So there's family support groups, there is peer support through programs like NAMI, there is kind of self-help, like things like calling a crisis center or reading something, but it really depends on the severity of the situation. So I would like someone to get that checked in, like check in with a provider, like a medical provider, to assess, like, are things stable enough for them to kind of engage in some self-help or peer support until mental health services are available. But unfortunately, there is no kind of one answer of like the place where I've been hiding all the therapists.
Just aren't
Yeah,
enough.
there's just not enough. I think we have about 30 openings at service right now.
Well, you guys, I'm leaving early, but I'm gonna be here for Monday through Friday during the week.
Thank you.
Thanks for coming
Thank
today.
Okay, thank you.
Okay, our second question.
Yeah, there's a hand back there.
Oh,
Please.
I'm sorry.
Follow up to that.
Yes, please.
Please.
I'm just curious, because I discussed this a
Yeah.
lot with my own family members, one who's a med student. Why are there not enough? Why aren't more people going into these fields? There aren't enough doctors, there aren't enough mental health professionals. specialized type of doctoring, there's just such a shortage. And from what I've learned about the whole medical training process, is it seems like there's a bottleneck in the system, like there aren't enough slots in the schools or something. And so I don't know if that is truly the fact or not. And I'm just wondering if you know, being a psychologist, I think, or.
I'm a marriage and family therapist.
Oh,
but-
marriage and
yeah.
family therapist yourself, what is causing this bottleneck? Is it there aren't enough people interested in it, or?
So for people with my degree, there is actually some data showing enrollment is really low, so schools actually have unfilled spots at the master's level, and the reason being there's not enough payoff on the cost of the education. So like, you know what I mean? So during, like I went to graduate school in 2008, where there was like no jobs to be had, right? So I was like, okay, I might as well just go to graduate school. But once the economy is doing better, less people get advanced degrees because they can have equally well-paying jobs, not having those really expensive advanced degrees.
But can I address that too?
Yeah.
The Economist a few months ago came out with something with just that question, and it was quite interesting. They were also finding that the bottleneck might be created by these accreditations. Like they want to keep the supply down. I mean, they want to keep the supply down so there's a demand. But they were finding that there are studies that show that people who get online training on like CBT, cognitive behavior therapy, are as effective as a trained therapist. And I was blown away by that. That people, so I thought, and the gist of the article was saying, well, everyone should kind of take that training to enhance, as a teacher, the coach. And so I just put that out there.
Yeah, and I think there's more and more kind of the peer support world is growing with kind of less formal education but more lived experience and people who are able to support each other. I think that's a part of the field that is growing. Yes?
Yeah, I'm officially a certified peer counselor, and we are just as effective as degreed individuals, as people with 4 years or more of education, but we're more cost effective. But it's interesting to see what will happen. We have to push ourselves if we want to get jobs in the county. We have to push to do that. So because people are often just not trusting peer counselors, thinking, what is this? I don't understand. But we do quite well, and we do help a lot of people. And we do have the HOPE program, which is helping our peers emerge. There's a handout over there. So we've got plenty of people. Somebody here at the California Clubhouse probably knows more about it than I do. But it is a program where we are matching people with peers. And it is shown to be one of the most effective types of counseling. And then regarding going online, I have a friend who goes to YouTube all the time for like meditation, to his mental illness. So it's nice that social media is, there's some bad to it, like harassing and bullying and whatever, but there's a lot of good stuff in there too. So yeah, hit that internet. It's really advisable. My friend loves it. It really helps her. Yeah. In fact, to make you Google, she goes to this one site. Somebody had told her to do this, actually a counselor, and she said, oh, well, I love pets. And so she goes to a place on the internet where there are dogs and puppies and cats, and she looks at them for the day. She looks at them, makes her happy.
Yeah, I appreciate you saying that like the web can bring both like stressors but also be positive, because I think for people who experience a lot of isolation, the internet has actually like been a way that folks have found community without, like, if they're not able to or comfortable leaving their home, or the internet has been a very valuable resource to folks who need community but aren't able to access that in their immediate lives. I have a hand.
I heard a statistic as far as like nursing school, and that it's so hard to get into nursing school, even though there's plenty available. San Francisco State, up and down the peninsula, there's plenty of programs, because the instructors can make more money if they go to work as nurses.
It goes to work as what? As nurses.
Yeah, if they go to work as nurses, then being instructors, they can make better money, and especially with the cost of living here. So there's just not enough instructors to populate the schools that are available.
That's surprising considering how expensive it is to get an education here in California. So it's surprising to hear.
So with the person you're needing help, would you recommend to go to marriage counselor or a social worker or the psychologist? What would be the first way to go?
So she's asking kind of where should people start if they're looking for help. I think it really depends on the nature of the help they're looking for. I don't think any of these professionals that you named are better or worse at helping people, but it really depends on what kind of help people need. So when we talked about things like peer connection or support groups, if the person is hoping to connect on what they're dealing with and that would reduce their stress or worries, then those are the correct avenues. If they're looking for medication, we suggest that they go through their medical provider and get referred to a psychiatrist potentially. So it really depends on what is the help somebody needs. If they're looking for insight or behavior change, then I would say a therapist or a social worker is an appropriate place to start. But they could also still attend peer support for that as well.
But then, when you talk about the symptoms, right,
Yeah.
like anxiety disorder, depression,
Mhm.
possible, and if we kind of observe, maybe this person need to be seeing doctor, right,
Yeah.
to be able to tell what's going on, what would be the better solution. Should the person just go ahead to see a doctor, a certified doctor?
So from a legal ethical place, I have to tell everyone, start at your medical provider. If you have access, start at your medical provider, because that helps people rule out, are the symptoms as a result of a mental health challenge, or are they actually a byproduct of a physical problem? So, for example, if someone has a thyroid condition, the symptoms that they're usually presenting with look a lot like anxiety and depression. And this is why coming to me first is not always, because I would then diagnose that as a mental health challenge. But ultimately, when people go get their physical, they're told, actually, you have an overactive or underactive thyroid. So that's an example of why usually we recommend that people start with their medical provider. And in most health insurance systems, they make you start at your medical provider. If you have Kaiser, if you have any kind of HMO, you have to start at your medical provider before they let you go see a mental health therapist.
I have a,
Yes, please.
so I have suffered from severe depression, been in the hospital 5 times, had almost 100 ACT treatments. And when I was too sick to ask anybody for help, I physically couldn't call anybody. So it was really my family. My daughter has the same profession as you did, and she thought I was suicidal. And it wasn't, they physically brought me to the hospital, So I think sometimes if you're so down, so in the pit, it takes another person to see what you're going through.
I appreciate you sharing that.
The power of one card sparked
Yeah.
5 or 6 more questions, so we did have a lot. There's one more card, and it says, many times when someone or yourself is depressed, it doesn't help when the other person you're opening up to just says, well, why don't you just pray?
Yeah.
How would you respond to that religious question? Or is there really a response? Because you kind of talked about how you send people to other resources.
And I would say, let's just replace that with anything, right? Let's replace it with yoga, so that the things I'm about to say doesn't feel offensive. If there is a coping mechanism that works for me, suggesting it to every other person that I talk to who's having a hard time is misinformed. Because it doesn't take into account that they might have different things that work for them, that they might have different sources of strength in their lives, and it doesn't trust that they've already tried some things. So we always want to trust the fact that somebody has already tried something. So before giving advice, I would ask someone what's going on for them, hear them out. One of the things we tell people on the crisis line is you don't get to give advice or referral before you've heard the story. So we tell them, in the first few minutes of the call, you don't get to give people a referral because you haven't heard the story yet. And that goes for all of us in our lives. We've got to hear the story first. What's going on? What's happening? Is this new? Has it been going on for a long time? And then trust that the person's done something. What are some ways you've tried to deal with this? It's rare for us to be the very first person they're talking to. It happens. But usually the person has tried things. They've tried to think about it at least, or it's been keeping them up at night. Let them hear us say that we trust that they've done something. So we always ask people, what are some things you've tried? And then, this is what I call connect people to their own resilience. I ask them if they've ever been through a thing that's kind of like it before. Has something like this ever happened for you? What'd you do then? right? Because then you're kind of getting the person to give themselves some advice, and you're reminding them through storytelling that they've gotten through stuff before. Most people have gotten through something before. So giving them an opportunity to tell you that story can help them kind of remember that. Because when we are stuck, when we're in a really bad place, it feels like all of our problems are like unsolvable. But if somebody asks me like, well, has something like this ever happened to you before? And if I say, well, not like it, but something like this happened. Okay, what'd you do then? Oh, I did X, Y, and Z. Was that helpful? This part wasn't. Do you think any of that would be helpful this time? Like, I didn't give any advice yet, right? And I've already talked to someone for 30 minutes, basically. So always noticing, one of the things I tell the phone counselors, and they're people who are not therapists or anything, they're people in the community, right? They're volunteers, is notice the need to give advice or referral, because that's your discomfort telling you something. That's you wanting to tell the person, stop talking.
Very good, thank you. I'd like to be sensitive to the time. This is from 3 to 5 p.m. I'd like to leave some minutes for you to get a little bit more food, or please visit the NAMI brochure desk here, or any questions you may have about the clubhouse.
And I'll hang around here if people want to come up to me and...
Sometimes the doctors will prescribe a pill. They're very quick to give you a pill for depression, so just to be aware of that. If you know someone is suffering and you send them to a primary care physician and they get a pill, maybe that's not enough. Just remember, okay, they have a pill, but maybe they still need someone to talk to.
For sure. And you could say, like, I'm actually not interested in that right now. Could I get referrals? So remembering that you have some say in your treatment as well. That some people might choose not to try that.
And I just wanted to address the comment or the question about like access, delayed access. And that is a difficult thing that I don't think that there's a really straightforward solution to at this time. But I do want to say and make note, Amal is here. He's one of our, I'm going to put you on the spot. He's one of our members of the Clubhouse, but he's actually the program director now of Heart and Soul, which is an organization right above us, and they offer free peer support. As well as groups, like they have a Hearing Voices group, which is a phenomenal support group for people who are hearing voices, like how to embrace that and how to live through that. But I shouldn't talk for you, but like, is there anything else that you want to say about Heart and Soul?
Well, there's also the drop-in centers at Central County and North County on Wednesdays and Fridays. It's like 10 to 2 at Central County on Wednesday and Friday, and 10 to 2 on Wednesday at North County, and then 4 to 8 on Friday at North County. And that's all free. Everything that Heart and Soul offers is free to the participants and is readily available. There's programming upstairs on Thursday afternoons. There's bingo and meditation that people can come to have fun and also to have some meditation, so it's good for centering. So there's